Good day and welcome to today's presentation. Please note this webinar is being recorded. All participants are in a listen-only mode. If you would like to ask questions, please enter it into the Q&A panel located on your screen. It is now my pleasure to turn the call over to Sophia Autry. Please go ahead.
Thank you so much, Amy. Good afternoon. We are very pleased to have you joining us today for the second installment of our comprehensive nursing home training. My name is Sophia Autry. I'm the Deputy Division Director for the Division of Community and Population Health at CMS, and I'm looking forward to a wonderful event today. A few reminders before we get started. The compliance slide and the recording for today's session will be posted to the QIO program website, so be on the lookout for that. We will post the link to the chat for those of you who are not familiar with our QIO program website, and that is qioprogram.org. During the open discussion period and Q&A, please keep in mind that we will get to as many questions and comments as time permits, but if there are any unanswered questions, we will address those as well after the event and post those to the website. Along with our speakers today, we have Kathleen Lawrence from our Division of Nursing Homes within the Quality, Safety, and Oversight Group at CMS, and our CDC colleague, Dr. Namali Stone, who are both available to answer questions. I want to thank both Kathleen and Dr. Stone for being available to assist us during the discussion. Slides and resources for this event can be found on the QIO program website. Please also note that we will have a post-event survey that will be shared via the link in the chat and after the event is over. Please complete the survey and let us know how we can make these and other trainings possible and improve them in the future. Next slide, please. Okay, so today I'd like to introduce our speakers. We have four impressive speakers for you today. Eli DeLille, who is an infection preventionist at Health Services Advisory Group, HSAG. Deb Smith, who is an infection preventionist at Health Quality Innovators, HQI. Dr. Kimberly Rask, who is the Chief Data Officer at Alliant Quality. And Susan Purcell, who's a Project Director at TMF Quality Innovation Network. Our first speaker will be Eli DeLille from HSAG. Mr. DeLille serves as an infection preventionist with more than 16 years of experience in the healthcare industry, with expertise in quality improvement, analysis, and implementation of performance improvement, patient safety initiatives, and direct patient care. Mr. DeLille earned a master's degree in nursing from Marshall University. He is certified in infection control and is a fellow with the Association of Professionals in Infection Control and Epidemiology. I will now turn the call over to Eli DeLille. Eli, the virtual floor is yours.
Thanks, Sophia, for the opportunity to be here today as well as the introduction. I'm going to talk about establishing an infection prevention program as well as conducting ongoing infection surveillance in the nursing home. Next slide. Some key elements of infection prevention, is developing a system for preventing, identifying, reporting, investigating, and controlling infection and communicable diseases for all residents, staff members, and visitors. And this sentence really does not give credit to the work that infection preventionists are doing right now, nor how challenging this profession is today. I do want to provide tools and resources that are going to help you as an infection preventionist establish goals and priorities for your program. And we want to work on planning and implementing strategies to achieve goals, monitor compliance, and also respond to identified issues as they develop. Next slide. I can't really talk about infection prevention without talking about the importance of training and education for our frontline staff members and allocating from an administrative perspective the time necessary for our infection preventionists to be adequately trained for this role. The designated lead at every facility should take some sort of training. In California, we have a program through CDPH, but at a national level, we have programming available from the CDC. This is self-paced, on demand that can be taken at the comfort of your office. There's no fee associated with this. There's continuing education available, and even the busiest infection preventionists can find 20 to 30 minutes to take the shortest modules And then some of the modules are a little bit longer. So we highly encourage this training for every infection preventionist out there. Next slide. As great as the CDC training is, it can't adequately prepare an infection preventionist to actually work within their facility. So additional steps need to be taken to orient them to their facility. So at HSAG, we're fortunate to have 50 plus years of combined infection prevention experience between 4 staff members. So we took that and condensed it down into a 3-page document that walks that new infection preventionist through an orientation that helps them learn what key resources they need to look at. It standardizes the essential components, and then also if you have one infection preventionist working at your facility, that's great. But unfortunately, that's not what every facility is able to do right now. They sometimes are splitting it between 2 or even 3 staff members. And what this is intended to do is ensure that there's consistency in your answers, because we don't want to confuse staff any more than what they may already be, especially in this very stressful, difficult time. We want to make sure there's a defined criteria so that if you are questioned by surveyors how you oriented your new infection preventionist, you can pull this form out and very clearly show them exactly what steps were taken to make sure that they can effectively do their job. Next slide. Now, as you get that fundamental knowledge developed through the CDC training, you've been oriented to your new role. Hopefully you're not dealing with an outbreak situation. You're just in a hotspot county if you're on this particular phone call. But there may be some of you that are in the midst of an outbreak just wondering where to get started. And the CDC developed this training, or actually this assessment, for public health officials to go out and help with COVID-19 to figure out exactly where there may be opportunities and processes to see if there's a disconnect between maybe your policy and what's actually happening out there. It's a quick assessment, it's 13 pages long, and it's a great way as a new infection preventionist to know where you have opportunities for improvement. What this also does is condenses a tremendous amount of recommendations from the CDC in a very easy to follow format. So as you do it with your team within your facility, you can take immediate action following the assessment. Now, it breaks it into 5 different components here, but I don't want to go too in depth because these areas are going to be covered later on in the presentation. Next slide. Once you've got your assessment completed, we're on step 4 now. You've likely found some opportunities for improvement, and you need to document what those opportunities are. You need to have a clear timeline, because in infection prevention, you can throw too many fixes at the problem and not really understand what exactly fixed it in the end. So having a format that you can really condense your thoughts into one document to share with your providers, with your team, with your frontline staff, to make sure everyone else is on the same page. And we left a spot here for your survey findings to the ICAR. You could use your local, state, or even federal survey findings to help populate this information. We have general recommendations from the Centers for Disease Control here for you to be able to have that really high level recommendations, but then also you want to customize it to your local and state, because they're ultimately who you have to follow to ensure that COVID doesn't get a foothold within your facility. You want to make sure that you know who is clearly responsible for the plan components. And right now, it should align each line. So 1, infection prevention manager staff, 2, maybe another individual, so that it's really clear accountability on who's supposed to follow up. You need to have a date, a timeline of, let's say, when you began your implementation, so that you can show over time how you kept COVID from coming in. And then finally, you need to be monitoring your data. NHSN is something that facilities across the country are mandated to use. State health departments, CMS, as well as local health departments have this information, and the QIOs as well. And we are using this to help focus our efforts on those people or facilities that need help the most. And having accurate data is extremely important. So if you have concerns or questions about what you're entering, please reach out to your QIO, because we're waiting in the wings to help. Also, as you're looking at your outcomes, we need to be monitoring process measures. So we know that the items that contribute to COVID is when people don't follow hand hygiene recommendations. They don't follow your cohorting, isolation, environmental cleaning, and many other things that we're going to talk about today. So tracking and trending that information so that if you see a decrease in hand hygiene and an increase in your COVID, you can go out to staff and reinforce the importance of their intervention so you know exactly what's contributing to those additional cases of COVID within your facility. Next slide, please. You cannot complete a plan in isolation. I know as a brand new infection preventionist, I thought I could read the best practices, sit in my office, and come up with something that everyone would love. And that's unfortunately not true, especially in the dynamic environment each of you are working in today. You have to get your medical staff, your pharmacy, your nursing staff especially engaged, because they're the champions that are going to help you be successful as an infection preventionist. There's only so many hours in the day, and you can't be everywhere for everyone. So the more people that out there that understand the reasons why behind what you're asking them to do. So you have to be very clear with staff regarding the expectations of care. You want to empower your staff to speak up if they identify concern. I had a meeting with a nursing home just before this, and he said that he's really taken the time with his environmental services for them to come to him and tell him when they're worried about something, and they've become one of his most important advocates out there as they try to combat COVID-19 within their facility. And you want to be willing to modify the plan as necessary. There's a facility in California that one day they were fine, they had just had a survey, but due to staffing concerns, call-offs, illnesses, the following day they had to be evacuated. So that's a horrible situation for everyone, but realize that no plan can sit in isolation right now. We have to be willing to adapt it very quickly to the changing demands or what you're experiencing with your particular facility. Next slide, please. CMS asked that when we came today that we share resources that you can immediately take following this presentation to your facility and implement them. They'll be in the chat board. It'll also be on the QIO website. So feel free to reach out if you have questions or concerns on how to implement this at your particular facility. Next slide. And then we're going to go two more. Can you go 2 slides ahead? There we go. Thank you. I'm also going to talk today about implementation strategies for COVID-19 surveillance and early detection. Unfortunately, IPRO couldn't be here today, and I was asked to present their information for them. Next slide. And they really focused on CDC's 3 key steps of basically keeping COVID out. And that has to do with screening appropriately, making sure that you're doing source control and a host of other interventions that we're going to cover today on this presentation. We also want to detect cases quickly, and that's through a lab-based approach, but also a symptom-based approach. And then hopefully with all the strategies we talk about today, we're going to stop transmission within your facility. Next slide, please. Our experts at IPRO really wanted to focus on sharing key strategies from the front line, and I'm going to do my best to get through these and give you examples as well of where there may be continued opportunity for improvement or something that you might want to think about at your particular facility. So wellness checks upon everyone entering the facility. It should be a standardized format that everyone comes through that's going into work. And you really should be looking for updated symptoms. I know the CDC is keeping this very up to date on their website, and it's something that the infection preventionist needs to be checking on a regular basis. You have to keep a line listing of these symptoms and then also refer to your local health department if there's additional steps that need to be taken. If you have longer shifts than normal, let's say you've been forced to switch to 12-hour shifts, it's a good idea to have more frequent touch bases throughout the course of the day, because there has been instances where asymptomatic staff members become symptomatic throughout the course of the day, and we would not want them to place residents in jeopardy. And that comes into assessing at the end of the shift as well. As they're leaving, they may be scheduled the very next day, and we don't want a situation where they're being pressured because there's no coverage for that particular facility. We want to make sure as people are coming in, that's a perfect opportunity to let them know what's happened since the day before. It's also a great opportunity for them to wash their hands as they're entering the building. The same nursing home I met earlier with today, they have a restroom right beside their screening area. Everyone goes in there, washes their hands before entering the building. If they are wearing personal protective equipment, they ensure that it was just then donned, and they're not bringing PPE in potentially from another facility that is COVID and exposing their residents unnecessarily. And then finally, you want to stagger the shifts. Socially distancing from one another is a crucial component of COVID control within your particular facility. And if you have 15 or 20 staff members coming in at the same time, it's going to be hard to screen them and also have the shift start when it's supposed to. Next slide, please. At an operational or organizational level, I mentioned before, we know that staffing is a crunch right now, but we don't want to pressure staff members to work when they're ill. There's examples of where symptomatic staff members have worked and they can trace the transmission of COVID to residents from that. So we have to be very, very cognizant that we want our staff members to let us know when they don't feel well, and that way make them comfortable that if they can't work, we recognize that. We don't want them to. I've already mentioned the 12-hour shifts. Agency staff, once again, there is a crunch out there, but if you have a agency staff member working at 2-3 facilities in the same day, you are exposing your facility potentially to maybe there's an outbreak at another facility and you're the last one in the day that are still COVID naive. So you have to have controls in place to make sure that your residents are not unnecessarily exposed. And you have to prepare for those staffing shortages, universal workers, waiver jobs. We've heard a lot about staff members working in different roles than what they're accustomed to, or administrative staff all of a sudden helping to take care of residents on the front lines, clinical resident staff, administrative staff. And it's very important that they're appropriately trained for their role because they may have been away from the bedside for an extended period of time. And then finally, volunteers. In California, we've been notified of a group of physicians, nurses, and retired infection preventionists that are going out willing to help some of our at-risk partners out there. So you want to be working with your local, state, and your QIO to know what resources are available so you can take advantage of those. Next slide, please. And then communication. I talked a little bit about as staff are coming in the building, letting them know what's going on. This is a really difficult time for everyone. The residents are nervous, their families, the staff members, there's a lot of unknown. So taking advantage of technology with email, text, webinars, face-to-face communication during these touch points is really important right now to keep everyone on the same page. And then another area that IPRO's identified, as well as we have in Arizona and California, is when we look at visitors, most of us think of family members coming into the building, but this includes your support staff, your contractors that are coming in the back door, bringing supplies or materials or food services. They're going into multiple facilities, and many times they may be trying to enter your building without washing their hands or source control. So you have to not forget that these people are still coming in and have a process in place to limit their exposure. And that may include having them leave things outside so that you can intake it and then safely bring it into the building. And then finally, have a clear return to work policy. As I mentioned before, sometimes people are feeling pressured. We've heard that from staff members or administrators who just, they don't know what else to do or where else to turn. But you have to have a plan in place with your local health department to know when a staff member can safely come back to work. Next slide, please. Now, if you have unfortunately been unable to keep COVID out of your facility, there are some things that you need to make sure that you're doing immediately and have been doing up until this point so that you quickly identify when there is a COVID positive or suspected resident within your house. They need to be checked, your residents, daily for signs and symptoms. Many of our homes are going to twice per shift just because this is such a concern. And then having more frequent touch points through staff so they can escalate a concern is extremely important. Mid-shift huddles is a great way to do that. I know everyone's strapped for time, but what we found with our partners is the more times you're communicating and they're bringing their concerns to you, the less chances that you're going to have a symptomatic resident out there unnecessarily exposing other residents or staff members. And then back to basics about good assessment skills. I've been a nurse now for, I think, 18 years, and watching for those subtle signs and symptoms is very difficult with the elderly population. So having everyone from the front line all the way up to the administrator out there watching for changes in these subtle signs and symptoms is a great way to start. And there is a program through Interact. It's called Stop and Watch. And unfortunately today I don't have enough time to cover the material, but I encourage all of you to check that out because it's a great approach to use with your staff to make sure that they're seeing these subtle signs and symptoms and escalating that concern. Next slide, please. And finally, the things that we're talking about today together will stop transmission. I have some brief pieces here that talk about the importance of engaging your resident in their care, explaining to them how important hand sanitizer and cleaning is, the fact that if they're bringing things from one area to another, that can unnecessarily contaminate something, letting them know there's a reason why they're being put in isolation or asked to be wearing a mask when they're exiting the room or to be cleaning things more frequently. These are all ways that you can get them be part of your team so that they don't see it as they're being restricted, that they're part of the team that's keeping COVID from getting worse within their particular facility. And then IPRO included some fun activities to keep residents engaged. We know that depression is something that each one of them is fighting right now. It's difficult for them not to see their family and friends. So we all have to go, I think, as much as we can to keep them as engaged as possible and also as happy as possible as well. Now, the other speakers are going to cover some additional details on how we can stop transmission. There's another slide that talks, next slide, please, about the resources that were shared during IPAR's presentation. Next slide, please. And I want to thank Marguerite and David for the opportunity to present their information today. I'm going to turn it back to Sophia. Thank you.
Thank you so much, Eli. As a reminder, we will have a Q&A session at the end of the call. However, you are welcome to submit your questions at any time during the presentation. Just click on the Q&A tab at the bottom of your screen and type in your question to submit. Our next speaker will be Deb Smith from Health Quality Innovators. Ms. Smith has more than 20 years of experience as an infection preventionist, registered nurse, and ASCP registered microbiology technician. Ms. Smith is a member of the Virginia chapter of APIC. Ms. Smith holds her certification in infection control, and she is a certified professional in healthcare quality. Take it away, Deb.
Thank you, Sophia. Next slide, please. So my topic for today's training is cohorting as a core intervention of an infection prevention program, and it's currently being utilized during the COVID-19 pandemic. Next slide, please. The goal of cohorting or isolation is to prevent the transmission of microorganisms from infected, colonized, and or asymptomatic residents to other residents, staff, or visitors who could then in turn transmit them to others or become infected or colonized themselves. Residents infected or colonized with the same infectious agent can be cohorted to prevent spreading that infection to other non-infected residents. Staff are also included in cohorting during outbreak situations like the COVID-19 pandemic to a specific cohort of infected residents. This further limits the risk of spreading infection in the facility. Next slide, please. To contain disease during the COVID-19 pandemic, the CDC outlines a plan for nursing homes to create a COVID care unit in their facility that can be dedicated to care for residents with confirmed COVID-19. This COVID care unit should be physically separated from the rest of the facility and be in place before the first suspected or confirmed COVID-19 cases. The COVID care unit can be a dedicated floor, unit, or wing in the facility, or a group of rooms at the end of the unit that's separated by a barrier, and it will be used to cohort residents with COVID-19. Nursing staff should be dedicated to work on the COVID care unit when it's in use. If ancillary staff cannot be dedicated to the COVID care unit, they should be restricted from entering that unit. Next slide. There should be posted signage at the entrance of the COVID care unit instructing anyone who enters the unit to wear eye protection and an N95 or higher level respirator at all times while on the unit. Following the CDC's PPE optimization strategy, a face mask can be used when respirators are unavailable. Cloth face coverings, however, are not considered PPE and should not be worn when PPE is indicated. Gowns and gloves should be added when entering resident rooms to perform resident care. Provide infection prevention training that includes the use of and steps to properly put on and remove the recommended personal protective equipment. Any resident care equipment should be assigned and dedicated to the COVID care unit. Cleaning and disinfection of this shared equipment should be performed between resident care, and this equipment should not leave the COVID care unit. Next slide, please. You'll need to assess your on-site and remote staffing capabilities to assure that you have adequate clinical and non-clinical staff with the required training skills and competencies in place for staffing the COVID care unit. These assigned and cohorted staff should not work across other units, floors, or facilities. If your facility doesn't have enough ancillary staff to dedicate to the COVID care unit, nursing staff may be needed to perform housekeeping and/or dietary tasks, so they will need extra education in these areas. Whenever possible, it's recommended that nursing homes integrate consistent assignment of staff to specific residents, with the goal being to decrease the number of staff and resident interactions. Staff access between the COVID unit and the rest of the facility should be limited as much as possible. This can be accomplished by providing a separate entrance and dedicating break areas and supply rooms for the COVID care cohorted staff. Next slide, please. Keeping the resident and the family informed of the cohorting process is the first step in managing a resident with COVID-19 symptoms. Residents in the facility who develop symptoms consistent with COVID-19 should be prioritized for testing and moved to a single room pending results of that testing. They should not be placed in a room with a new admission, nor should they be moved to the COVID care unit until they are confirmed to have COVID-19 by testing. Roommates of residents with COVID-19 may be exposed and should be considered infectious and moved to a single room or observation area. You can cohort potentially exposed residents in an observation area only if single rooms are not available. Residents with known or suspected COVID-19 should be cared for using all recommended PPE, which includes the use of an N95 or higher level respirator, eye protection, gowns, and gloves. Next slide. If your facility is receiving new admissions or readmissions who have been confirmed to have COVID-19, you'll need to carefully assess each resident for placement in your facility. If criteria for discontinuation of transmission precautions has not been met, they would be admitted to the COVID care unit. If they have met the criteria for discontinuation of precautions, they would be admitted to the regular unit. When admitting residents with unknown COVID-19 status, they would not be cohorted on the COVID care unit, but they would be placed in a single room or in a separate observation area so the resident can be monitored for evidence of COVID-19. Staff should wear all recommended COVID-19 PPE when caring for these residents. These residents can be transferred out of the observation area to the main facility if they remain afebrile and without symptoms for 14 days after their admission. Next slide, please. Continue your transmission precautions and cohorting for all symptomatic and asymptomatic COVID-19 positive residents until the criteria for discontinuation is met. The criteria on this slide are the CDC recommended strategies for discontinuation of precautions for symptomatic and asymptomatic residents, but it's important to remember that if your state or local regulations are stricter and include a longer duration, you must follow those stricter regulations. If a symptomatic resident declines or is unable to be tested, you would continue transmission-based precautions until symptom-based criteria are met. Next slide, please. Finally, contaminated healthcare facility surfaces play an important role in the transmission of microorganisms, including COVID-19. Therefore, appropriate cleaning and disinfection of surfaces and equipment which residents and staff touch is necessary to reduce exposure and minimize the risk of cross-infection from one person or object to another. So environmental cleaning should be enhanced and include at the very minimum daily cleaning of all high-touch surfaces more frequently. Next slide, please. In closing, I'd like to mention that each of your facilities are unique and that you may need to adapt these recommendations to your facility. These adaptations will rely on your access to PPE, the available space, and the number of COVID-positive residents you currently have. You can always reach out to your QIN/QIO or your state or local health department for assistance with any unique situations you encounter. So thank you very much for your time today, and I'm going to turn this back over to Sophia.
Thank you so much, Deb. Our next speaker from Alliant Quality is Dr. Kimberly Rask. She's the Chief Deputy Officer at Alliant. Since 2008, Dr. Rask has provided clinical and analytical direction for economic evaluations, patient safety initiatives, and quality data reporting. A primary care physician and health economist, Dr. Rask also holds academic appointments with her research focusing on quality improvement and outcome measurement, with particular attention to rural and underserved populations. You are welcome to begin, Dr. Rask.
Thank you, Sophia. Today I'm going to talk about 3 aspects of the clinical care of COVID-positive residents that is helpful for your staff, to be aware of as they care for them. First of all, residents with COVID can have a very different experience and very different disease trajectories. Second, it's really important to have care plans in place that align with the residents' goals and preferences before they become sick. And third, make sure that you work with your medical directors to see that all necessary medications are available should your residents need them. As you know, COVID-19 is a new infection to us, and we are continuing to learn more as time goes on. We still do believe that most residents will develop symptoms within 2 to 14 days after being exposed to the virus. What is changing is that early on we focused more upon the respiratory symptoms from COVID, things like fever, chills, cough, difficulty breathing, sore throat, or a runny nose. And over time, we're recognizing the symptoms can actually be much less specific. Residents may have headaches, feel tired, muscle aches, lose their taste or sense of smell. Whereas we used to think of COVID as a respiratory disease, we're now thinking of it as a blood vessel disease. And that means that COVID-related symptoms are actually much broader and may not be very specific at all. If we think then about the clinical course, we may see residents experiencing COVID very differently. Some residents may have no symptoms at all. Some may have minor symptoms and then recover, and some may have minor symptoms, but after a few days or weeks, rapidly get very sick and have multi-organ failure. And for this reason, the Centers for Disease Control is recommending that we monitor all COVID-positive residents more frequently than we normally do in our facilities and really pay attention to symptoms and any sign that someone's clinical condition might be changing or worsening. Next slide. If you can go to the next slide, please. In addition to being very aware that someone who is not very ill now may become very ill quickly, we also are recognizing that many residents will not have the classic COVID symptoms. It's very common to see residents that will only have subtle changes in their level of tiredness, their level of alertness. They may slowly stop eating and drinking over a couple days or maybe a couple weeks. What this means is you may have a very non-specific downhill course over several weeks. And as the earlier speaker mentioned, this is why the awareness of everybody from the frontline staff to the administrators in a facility to really pay attention and notice how individual residents are doing. Ideally, residents are with staff who work with them regularly and are able to catch these signs. In these chaotic times with cohorting, we know that often there's staffing changes. Given that, it's really important that staff have open lines of communication so that they can share with each other any concerns, or if they notice something, the next person on the ship can pay attention and see whether, yes, this is a real change in their ongoing behavior and something that we ought to pay attention to. Another thing to keep in mind is that COVID-19 is also being associated with blood clots and strokes, which means that some residents may show their COVID symptoms simply through an altered mental status without any other symptoms. Next slide. So now we'll move to our second point, making sure that appropriate care plans are in place in order to respect resident goals and preferences. Advanced care planning is important for all residents, but it's particularly important in today's era with COVID. As we mentioned earlier, some residents with COVID will have minor symptoms for several days or weeks and then suddenly become acutely ill. It's really important to have those conversations about care preferences and to document those preferences long before a resident becomes sick, and decisions have to be made quickly. The main question here for most patients with COVID is whether or not the resident wants to be transferred to the hospital. As you know, at this time, we do not have an effective treatment for mild or moderate COVID. What we can do is provide supportive care as the virus runs its course. Ventilator support for acute distress in breathing is available in a hospital, but it's important for you and your staff members to know, and for residents and their families to understand, that the experience that we're finding is that there's a very high mortality rate for older persons who are put on ventilators with COVID. The published literature is reporting a mortality rate of 80% for people over the age of 80 who are placed on a ventilator. And even for those younger than 80 but with underlying medical conditions, the mortality rate approaches 75%. It's really important that residents and their families are aware of this as they think about what their preferences are. In doing advanced care planning, make sure that the residents' care preferences can be honored if a health crisis develops. Next slide. So finally, thinking about what resources you have available in your facility. It's important to work with your medical directors to make sure that any necessary medications will be available quickly should a resident need it. Think about having standing orders for Tylenol, supplemental oxygen, and discontinuing any non-essential medications. Also be sure that the staff is trained as to proper resident positioning in order to improve breathing, what we call proning. And consider changing nebulizers to metered dose inhalers if possible to decrease the risk of COVID transmission from an infected resident to staff. One area that some facilities have to pay particular attention to is making sure that concentrated opioids, which are used for severe shortness of breath symptoms, are available quickly. If a resident is in distress, you do not want them to have to wait several hours until a medication can be made available from the pharmacy. And finally, I want to point you to the CDC resource at this link. It's a comprehensive source of information about how to evaluate and manage residents with symptoms of COVID-19, and the information is updated frequently as we continue to learn more about this disease. Thank you, and I will turn it back over to you, Sophia.
Thank you, Dr. Rask. Our final speaker for today is Susan Purcell from TMF Quality Innovation Network. Ms. Purcell has been a registered nurse for 34 years, working in critical care, home health, hospice, and nursing management. Ms. Purcell has been with the QIO for over 16 years, leading quality improvement projects in case review, nursing home, hospitals, and outpatient settings. Susan, the floor is yours.
Hello, everyone, and thank you, Sophia. And also thank you to Telligence, the Quinn QIO, who originally authored this presentation on personal protective equipment. Next slide, please. The objectives of this PPE presentation is to provide you with why and how to use PPE and give you links to resources that can be helpful. You'll see that I've included numerous links throughout the slides for more in-depth information, and there's information in the chat about attaining the slides. Next slide, please. PPE is specialized clothing or equipment worn by an employee for protection against infectious materials. Next slide, please. We use PPE to protect ourselves, our residents, and others in the process of performing care, including protection from dangerous or infectious substances. Next slide. Listed here are types of PPE commonly used by healthcare providers to protect themselves, residents, and others when providing care. Gloves are the most common type of PPE that is used in healthcare settings. All of these serve to help keep us safe. Next slide. Based upon the CDC guidelines, PPE is to be used every day by all healthcare personnel to protect themselves, residents, and others when providing care. This also includes activities personnel, environmental services, dietary, administrative staff, hospice, repairmen, etc. There are also instances where residents must wear PPE for protection, including going out to doctor's appointments. More detailed information is available at the CDC link provided here under the tab Infection Control Guidance. Next slide. PPE must be donned correctly before entering the resident area and must remain in place and be worn correctly for the duration of work in potentially contaminated areas. PPE should not be adjusted, such as retying a gown or adjusting the respirator or face mask during the resident care, and must be removed slowly and deliberately in a sequence that prevents self-contamination. Have a PPE buddy system in case assistance is needed. A step-by-step process should be developed and used during the training and during resident care. Next slide. For more information on proper use of PPE, I highly recommend this CDC link. There are posters in both English and Spanish that can be used for staff education, as well as videos for educational purposes. I'll go over some of their guidance now. Next slide. Standard precautions are used for all resident care. Transmission-based precautions are used when caring for those with known or suspected COVID-19 infections. Proper donning, doffing, and use is necessary to prevent self and cross-contamination. So I'll go over those in more detail. Next slide. More than one donning method may be acceptable. Training and practice using your facility's procedure is critical. This is one example of proper donning. Identify and gather the proper PPE to don. Ensure the choice of gown size is correct. Perform hand hygiene. Put on isolation gown. Tie all the ties on the gown. Assistance may be needed by your PPE buddy. Put on your N95 filtering face piece respirator or use a face mask if a respirator is not available. If the respirator has a nose piece, it should be fitted to the nose with both hands, not bent or tilted. Do not pinch the nose piece with one hand. Respirator or face mask should extend under the chin. Both your mouth and nose should be protected. Do not wear the respirator or face mask under your chin or store it in your pocket between residents. Put on your face shield or goggles. When wearing a respirator, select the proper eye protection to ensure that the respirator does not interfere with the correct positioning of eye protection and that the eye protection does not affect the fit or seal of the respirator. Face shields provide full face coverage. Goggles also provide excellent protection for eyes, but fogging is common. Next, put on your gloves. The gloves should cover the cuff or wrist of the gown. Now you're ready to enter the resident area to provide care. Be aware of your surroundings and what you're touching. Next slide, please. This picture from CDC shows fully and appropriately donned PPE. Next slide. Removing PPE, also known as doffing, is an equally important practice to prevent self or cross-contamination. Start with removing gloves. Ensure that glove removal does not cause additional contamination of the hands. Next, remove the gown. Untie all ties or unsnap buttons. Some gown ties can be broken rather than untied, but do so in a gentle manner, avoiding a forceful movement. Reach up to the shoulders and carefully pull the gown down and away from the body. Rolling the gown down is an acceptable approach. Dispose in an appropriate receptacle. Exit the room or area and perform hand hygiene. Carefully wash all hand surfaces for 20 seconds and don't forget the thumbs. Carefully remove the face shield or goggles by grabbing the strap and pulling upwards and away from the head. Do not touch the front of the face shield or goggles. Remove and discard the respirator or face mask. Do not touch the front of the respirator or face mask. Perform hand hygiene after removing the respirator or face mask and before putting it on again if your workplace is practicing reuse. Facilities implementing reuse or extended use of PPE will need to adjust their donning and doffing procedures to accommodate those practices. And again, the CDC link at the bottom of the slide has more information. Next slide, please. Again, an infographic from the CDC with the information regarding removal or doffing of PPE. Next slide. Some tips for face masks. When you put on a face mask, perform hand hygiene and put the face mask on where it covers your mouth and nose fully. When wearing a face mask, don't wear it under your nose or mouth. Don't cross the straps or allow them to hang down. Don't touch or adjust the face mask without performing hand hygiene before and after. Don't wear your face mask on the top of your head or around your neck or threaded through your arm. And when you remove your face mask, clean your hands and remove by touching only the straps or ties, then perform hand hygiene again. Next slide. Again, a CDC infographic on these face mask recommendations. Next slide. Because there are often questions regarding optimizing PPE when there are supply shortages, and due to our time constraints, I have added some additional resources here from CDC on this topic. Next slide, please. And Sophia, I'll turn it back over to you.
Thank you so much, Susan. So now we would like to conduct an open discussion and Q&A session. So to submit a question, click on the Q&A tab at the bottom of your screen and type in your question. Please be aware, we will get to as many questions as we can in the time allotted. If we do not get to your question, we will answer the remaining questions after the event and post those to our QIOprogram.org website. As a reminder, along with our speakers today, we have Dr. Namali Stone from CDC and Kathleen Lawrence from the Division of Nursing Homes available to answer questions as well. So if there are any questions that you have, you can just submit those at this time. I'm not seeing any questions that people have, but I'll wait a couple of seconds in case people are typing. As we wait for some additional questions, are there any items that any of our speakers would like to reiterate at this point?
Hi, Sophia, it's Eli. And I actually had someone email me a question instead of using the chat feature. And it has to do with when a facility has an increased number of COVID residents, should everyone in the facility begin wearing a face mask? And they're referencing the CDC recommendations that were updated on July 9th. I was wondering if Namali could weigh in on that.
Dr. Stone, are you able to weigh in on that question?
Hey everyone, this is Namali. I'm sorry, Eli, can you read that one more time for me, please, sir?
Sure, they're asking about the use of universal face masks when there's an increase in COVID within their building, and they're referencing CDC, an update that was released on July 9th.
Got it. Yes. Universal face mask has been a longstanding recommendation as part of source control. And that goes way back before July. So trying to...
I might have missed face shielding. I apologize.
Oh, face shield. Okay, that makes sense. Yes, sorry about that. Okay, so universal face shields. On our general infection prevention and control guidance for healthcare facilities, not the nursing homes focused guidance, but actually the broader guidance, of which, you know, the nursing home guidance is sort of a subset of that broader infection control recommendations for healthcare facilities. There is language that talks about consideration of universal face shields or eye protection, basically, in addition to face masks, as a strategy to provide additional protection when working in communities where there's a growing prevalence of COVID transmission. And I'm trying to find the specific language if I can, but the reason behind that is it's one additional barrier, especially if you're able to use a face shield, because it's not only protecting eyes, but it's another barrier to people handling or accidentally touching their face mask. And we know that we have a lot of concern about asymptomatic individuals, healthcare personnel primarily, who have to go in and out of the community as they go back and forth from home to work, coming in and potentially introducing COVID into a building. And because they don't have signs and symptoms, they may not be aware of their infection and would not necessarily screen positive when being screened at the beginning of their shift. So to me, there's a role for putting one more barrier in front of people's face masks, because when we are accidentally touching our PPE, and if we were infected and handling our face mask without performing immediate hand hygiene, we can sort of become a source for spreading COVID incidentally to other surfaces or to other people. So that is a consideration, and in areas that are having a rise in COVID cases in their community, I think it's very reasonable to implement that if supplies allow.
Thank you so much, Dr. Stone. I do have a question for Kathleen, if you are able to answer it. We received a question about staffing requirements for nursing homes if there is a shortage or while we're in this pandemic. Can you answer anything about if there are any changes in staffing requirements for nursing homes currently?
This is Kathleen. Hi. Can you hear me okay?
Yes, we
there
can.
are no changes I'm aware of. The only guidance that we've pretty consistently given is just that nursing homes need to be able to care for the residents that they admit. So, and that would include staffing. It would include shortages of PPE. If they're admitting residents that need to be on transmission-based precautions, that kind of thing. So if they can't provide that type of care, they shouldn't be admitting. And that goes with anything beyond COVID, but especially during this time.
Thank you so much. And I want to remind everyone that the slides will be available after the presentation. And when you get those slides, the resources and links on those slides are available as well. So we have a lot of information that will be available and appropriate for this presentation. I don't have any other questions, but we are 6 minutes from the top of the hour, so we can go ahead and move to the next slide, Judy. Okay, so thank you, everyone. This is the end of our presentation. We would really like to thank you for joining the call today. We hope you found the information valuable and that you can utilize it in your services and facilities moving forward. So please take a moment again to complete the survey. It will be included in the chat, and you will also receive an email with the link to the survey post the event. And thank you again for attending. And this is the second of 5 sessions for a comprehensive training for nursing homes. Thanks so much. I know it's a Friday. Have a great weekend, everyone. That's the end of this session.
Thank you for your participation. That concludes today's presentation. Please disconnect now.